Okay, these are my disclosures. I have some research support to facilitate my research in epilepsy, and as Dr. Reed mentioned, I'm the chair of the ILAE Neuropsychology Task Force. Our learning objectives today is that I hope that at the end of this, you'll understand the general principles of neuropsychological assessment, that you'll be able to recognize the multiple factors that can influence neuropsychological test performance, and finally, to appreciate the role of neuropsychological assessment in the pre- and postoperative management of patients with epilepsy. So I put down as a disclosure that I'm the chair of the Neuropsychology Task Force of the ILAE, because much of the information that I'll be presenting today comes from the work of the task force. So I've listed here 3 key references, 3 papers that we've published. The first is a paper that is directed to the general neurologist, someone who has epilepsy patients but is not necessarily an epilepsy specialist. So this paper is on the 10 things that every neurologist needs to know about neuropsychological assessment and intervention in people with epilepsy. Another paper is on indications and expectations for neuropsychological assessment in routine epilepsy care. And then finally, our paper on indications and expectations for neuropsychological assessment in epilepsy surgery. So as you are well aware, a patient who is considered for epilepsy surgery has to undergo multiple investigations. And this diagram taken from this article by Philippe Rivlin indicates the range of investigations that are indicated. So in phase 1, the initial phase of investigation, there are 3 key investigations that have been identified: MRI, video EEG, and neuropsychological assessment. These, of course, are accompanied by other investigations depending on the particular complexity of the patient's case. So the neuropsychological assessment is key and is core to the epilepsy surgery evaluations. So the role of neuropsychology is to provide a comprehensive and objective assessment of cognitive and psychosocial function. And this serves several purposes. One, we want to answer specific referral questions that are directed to us. And in doing so, we take into consideration the patient's history and broader aspects of their function, not just what we discover during our assessment sessions. We want to provide diagnostic information, if possible, about lateralizing and localizing aspects of the epilepsy. And importantly, we need to be able to differentiate the neurological, the psychological, the social, and the environmental factors in the patient's presentation. We want to provide prognostic information about how we feel that the course of epilepsy will play out in the patient's cognitive and psychosocial function. And this is, of course, particularly important for children who have a long course ahead of them. And finally, we want to provide feedback and, where appropriate, interventions or recommendations for interventions. Now, I want to emphasize that neuropsychological assessment is not a standalone procedure. Our scores have to be interpreted in the context of other tests and clinical data, such as the EEG, the MRI, the fMRI, medical and psychiatric history. I've had people come to me and say, why don't you do your assessment blind? And the answer is that test scores are just a part of understanding where the patient, how the patient is functioning and how the patient has arrived at that stage. But there are many other factors that influence how a patient arrives at a particular test score. And we need this multitude of information in order to make that determination. So as I said, neuropsychology is not only tests and test scores, but in fact, we have to take into consideration multiple factors that influence performance on neuropsychological tests in epilepsy. And these can be divided into 3 major categories. There are the fixed factors, the nature of the underlying pathology, the laterality of the pathology, the localization of that pathology, the age of onset of the seizures and of the treatment, and the impact that the patient's history has had on his or her educational attainments, because education plays into test results, There are also possible differences related to the sex or gender identity of the person and the individual's intellectual capacity. There are also factors that can vary from patient to patient along the course of the disease. So whether or not the patient has a history of status epilepticus or generalized seizures or a history of head injury, any of these things can greatly influence the neuropsychological test profile. And the final category here are the remedial factors. And these are factors that can influence test performance, but that can be changed in order to optimize test performance. And these include variables such as medication, whether or not the medication has any cognitive or behavioral side effects, whether or not the patient is exhibiting interictal abnormalities, EEG abnormalities at the time of the assessment, the current seizure control, patient's mood, because we know that depression and anxiety can influence how well people can perform on tests, the patient's motivation to perform the tests, the quality of sleep. So if a person has not had good sleep, this can also have an adverse effect on test performance. And finally, the proximity of the last seizure to assessment. So we need to take all of this constellation of factors into consideration when we're looking at our test results in order to arrive at a formulation. This diagram comes from a relatively recent paper by Linda Gonzalez and Jackie Rennell, and it just is somewhat similar to the previous one, but it just shows that with children, perhaps there's even greater complexity of the factors that need to be taken into consideration in order to arrive at the neuropsychological formulation. So we have to know information about the child's epilepsy characteristics, the developmental history, their cognitive performance, the psychological dimension, family and social context, because we now know that family factors also have an impact on neuropsychological performance in children. And then there are the intrinsic factors such as genetics. Now let me just go through a few case examples here to illustrate this point that I'm trying to make about how a test score can vary in its meaning. So this illustrates an example of a typical kind of verbal memory task that we might administer in our evaluation. So we would read the patient a story such as this one. Terry Brown was fixing his lawnmower in his garage when he saw someone approach the back of his house. He went outside to investigate and saw a young man coming out of his back door with his iPad. He yelled at him, but the man jumped over the fence and ran away. Terry took chase and followed him down the street and across the park, but the thief disappeared into the trees. Terry then called the police and described the thief as medium height and dressed in ragged clothes. He remembered that the thief had on a red jacket, but he couldn't remember the color of his hair. So after reading this to the patient, we would ask the patient to tell us back as many details as possible immediately after the story, and then again after a delay. So let's look at some representative recalls. So this patient said, Terry somebody. There was something about a garage and a computer. There was a park and some trees. Did a man steal something? I can't remember anything else. Did he jump over a fence? So this person has got some general details of the gist of the story, but is greatly lacking in the specifics or the content. So this would result in a very low score and might be indicative of a verbal memory impairment. In fact, this is derived from the test performance of a patient with left mesial temporal sclerosis, and it would not be unexpected that such a patient would have a verbal memory deficit. Let's look at this patient though. Somebody broke into a man's house and nicked his stuff. He ran off. I can't remember the guy's name. I think he was a mechanic. It was a young boy, I think, with a baseball cap. So again, a few details, a bit confused, but not a great deal of content. So quite an impoverished recall, and again, a low score. This time, surprisingly, however, this comes from a patient who has right mesial temporal sclerosis. And you wouldn't necessarily think of such a profound verbal memory deficit in this patient. However, when we look at the patient's history, we know that he has frequent, widespread interictal discharges, and that is probably what is accounting for this poor recall, as opposed to just the mesial temporal sclerosis in and of itself. Patient 3 recalled, a man was in his house and someone stole his phone. And the examiner said, anything else? And the patient says, no, can't remember. So this is very, very poor. But in fact, this is a patient who was suffering from rather severe depression. So in this case, it was thought that the memory disorder was secondary to the depression. Patient 4. Mr. Somebody was outside. He saw a burglar breaking the window and stealing his TV, and he chased him away to the place where the police people are. So this is someone with poor recall and obviously having some significant word finding problems. And this is a patient who is on topiramate, which we know can result in side effects such as impairments in memory and also significant word finding problems. And my final example, this patient said, Mr. Tom Thumb was walking down the road when he was attacked by a tall man in an alley. He screamed for help, but nobody came. It happened in Toronto. I think he was ugly. And on and on and on he went with all kinds of details that he was making up that had no relation to the story. And in fact, this was a patient who had significant inferior and orbital frontal abnormality. And this is an example of confabulation. So in all of these cases, we have patients who had a low score on a test, but the reason for the low score varied according to these other clinical factors. And that's why we need more information in order to interpret a test score. Okay, I'm going to segue into some general principles about neuropsychological assessment. And these apply to the assessment of any patient with epilepsy, but also to those undergoing epilepsy surgery. So first of all, when not to assess? Well, if the patient has had a previous neuropsychological assessment within the last 6 to 9 months, we don't like to retest. And that is because there may be practice effects, and these practice effects can either mimic improvement or mask decline, and therefore give us a false sense of what's happening with the patient. There are some exceptions to this principle. So for example, if there's been a significant change in the patient's medical history, such as an episode of status epilepticus, or the patient sustains a traumatic brain injury, or there's some other acute illness or insult, then we may indeed say, yes, it would be a good time to go ahead and reassess. So an important principle, the patient has to be testable. We are not miracle workers. We're great, but we're not miracle workers. So if a patient who is referred to us who has very low IQ, then it is difficult to ascertain patterns of strength and weaknesses because the tests are not sensitive enough and are marked by floor effects. We have to consider the patient's language. If their first language is not the language that our tests are available in or that the examiner is fluent in, then this can represent significant difficulties. And it's not sufficient just to translate a test, because then there can be different cultural or language norms associated with the test. We have to be aware of sensory deficits like visual or auditory impairments. We need to ensure that the patient is well motivated, although we can use tests of effort to determine whether or not this is the case. We would like a patient who's able to cooperate with the assessment. And then obviously the age is important, because what you can do with, say, a child who's 6 months of age is very different from what you're going to be able to do with an 18-year-old or a 40-year-old. So what can we expect from a neuropsychological assessment, or what can you as a neurologist or a neurosurgeon who has referred someone? Well, obviously, we like to think that we can provide you with reliable and valid results in which we can make our formulation. And usually our report will have some comment about whether or not we think that the results are reliable and why we do so. We'll provide a quantitative assessment in core cognitive and behavioral domains. And what's important to think about is not whether specific tests are used, but the characteristics of those tests. Are they based on solid cognitive psychology criteria? Are the tests one that have been demonstrated to be reliable and valid and sensitive in patients with epilepsy? Are they tests that have appropriate norms, have been properly standardized, and are culturally valid? And thirdly, we will incorporate a qualitative assessment of the patient by taking into consideration the history of the person's complaints and also our observations during the assessment session, the approach to test, the behavior, and so on. In this box on the right, you can see that there are a number of domains that we like to assess in our evaluations: intellect, attention and speed of processing, memory, language, spatial functions, executive functions, sensory and motor, academic skills, if that's for a child or if it's appropriate for an adult, and then psychological domains. So because we want to try to cover all of these domains, we include many tests, and it's usually many of these domains are multifaceted, so it's often important, necessary to include multiple tests. Now, I've had neurologists say to me, why do you need to use so many tests? Why does your assessment have to be so long? And it's because it's important for us to cover these domains. And I often counter with the question, well, why do you use so many electrodes? Do you really need to sample all those areas of the brain? So we're doing the same thing. You can use that as an analogy. I want to emphasize that it's important not to forget the psychological and neuropsychological, because we know that our patients with epilepsy often suffer from the effects of stigma. They often have poor coping strategies. They may have mood impairments, and we need to consider the impact of epilepsy and the cognitive and psychosocial comorbidities on all aspects of the patient's life, their educational attainments, their employment, and their relationships. And all of these, of course, feed into quality of life. Now, in some programs, these aspects are taken care of by clinical psychologists or by psychiatrists, but in many programs, we don't have the luxury of having those specialties involved. So it's important for the neuropsychologist to at least screen for these issues and to make referrals when appropriate. I want to just spend a moment talking about subjective complaints. That is what the patient comes and tells you, because it's important to realize that these do not always correlate well with objective test results. We know that tests are constructed to test underlying processes, not real life functions. So we're thinking of, encoding and retrieval and interference and flexibility and switching and so on. And these might not be the things that the patient is experiencing in their real life, or might not be the terminology that they use, because patients and clinicians often talk a different language. So it's not uncommon for a patient to come to us and say, I have a terrible memory. And then upon evaluation, we discover, well, what is really the issue is that they have significant attentional problems, and that's preventing them from encoding information adequately into memory. Or what they're calling a memory problem is what we would call a language problem. They're having word finding difficulties. And we also know that subjective complaints correlate more strongly with mood than with objective test results. And I'll give you an example of that from a 17-year-old boy who underwent a right temporal lobectomy. And 4 months after he had his surgery, he wrote an email to his neurosurgeon saying, I find that I'm having trouble with my short-term memory. It has been more difficult for me to recall conversations that I had with other people a few hours after speaking to them. The problem gets worse week by week. When I try to recall conversations or events, then problems that I'm trying to solve, it's a huge puzzle. When I try to retrace conversations or events, the more time I spend doing so, the pieces to this puzzle start to disappear. Over the past few weeks, I find that these pieces disappear more quickly. I find that if the events affect me personally, like an argument, I'll be able to recall the event with no problem 1 to 1.5 hours later in detail. When trying to recall situations that don't affect me personally, like talking to another person or asking a teacher for help, I find that my memory can vary from 5 minutes to 1 hour. One situation was last week. I asked my chemistry a question during my lunch about the lesson taught earlier that morning. I understood the lesson after she explained it to me. And then after school, I went back to my chemistry teacher asking the same question. The only thing I remember was that I asked for help during my lunch. I completely forgot what I asked and what she told me. And he ended off with the question, is this normal after such a major surgery? So the neurosurgeon forwarded this email to me, and it became my problem. Those neuropsychologists who are in the audience might recognize that there are aspects of this description that don't necessarily fit the type of memory impairments we see after surgery. So this raised several questions in my mind. And before I reevaluated this patient, I recommended that he go have a consultation with psychiatry. And I also dug around and got some other information. It turned out that, in fact, he had a significant depression, even though he had initially denied having it. And furthermore, his sleep was very disrupted. He was going to bed very, very late and had very disjointed sleep. And thirdly, he was having very significant headaches every single day. And once these problems were taken care of, and I reassessed him, in fact, his memory was fine. He did not have impairments. If anything, it had improved after his surgery. And eventually he finished high school and went on to university to study engineering. So those other factors can play into these subjective complaints. So how do we apply the results? Well, we arrive at a formulation that addresses a referral question. We also want to provide feedback to the person with epilepsy to provide some insight and knowledge and psychoeducation around their difficulties. If appropriate, the feedback can be also delivered to the family so that they can gain a greater understanding. And if asked, we will also intervene with teachers and employers to give them relevant information and strategies that may assist the patient at school or at work. And if appropriate, we will make recommendations for interventions. Now let's go on to more specifics around epilepsy surgery. As I mentioned, we want to try to arrive at this detailed picture of the patient's cognitive and behavioral function. We want to know what their current function is, and we want to know whether or not there's been any evidence of change. Has this been a permanent pattern? Has it been something that fluctuates? Can we go back to think about those factors that influence neuropsychological assessment and decide if they are remedial, and if so, can we intervene on them perhaps before surgery? And we do this again by, as I said earlier, looking at the quantitative data that we gather, the qualitative data, and trying to get a full picture of the clinical context of the patient. We want to, with our assessment, establish a baseline against which change can be measured. So the epilepsy surgery is a pretty significant intervention, and we want to know the results of that intervention. Our assessment will make a contribution to this collaboration among other professionals to try to understand and characterize the seizures, their localization and lateralization. We are in the unique position of being able to provide evidence-based predictions of cognitive risks associated with epilepsy surgery. And finally, our results can provide evidence for pre-operative counseling, including discussions about the expectations of surgery and helping to make sure that the patient is fully informed when they go ahead to consent to the surgery. So this pre-surgical assessment that we do must be up to date. It must be recent. Something that took place 5 years ago is probably not adequate, particularly if there have been changes in the patient's seizure pattern or medication. We should be assessing function in all cognitive domains and include at least screening measures of psychological assessment. And for children, we have to include parent or caregivers' evaluations of behavior. So when we're thinking about the baseline and we're thinking about scheduling the assessment, we want to think about its proximity to the last seizure and medication effects, because these can impact the stability of the baseline results. And we want to make sure that we do have an accurate and stable evaluation in order to be able to make the prognostications and to contribute to that risk-benefit ratio that undergoes the discussions in epilepsy surgery. When we're thinking about the contribution of our test results to the seizure characterization, lateralization, and localization, we have to keep in mind that results have to be developed interpreted in a developmental context. So we have to know about the onset of the epilepsy, the duration of the epilepsy, the underlying pathology, and so on. And in so doing, we're really considering both organic and non-organic, both static and dynamic influences on behavior. And I want to point out that young children often present with diffuse profiles of impairments, even in the context of a localized seizure disorder. So this disruption with the development of the brain and the brain networks early in life can result in much more generalized deficits than we see in individuals who have later onset of their epilepsy. So let's think about identifying the cognitive risks of surgery and likely outcomes. And our research has identified that there are a number of variables that are predictive of these kinds of outcomes. And those factors are preoperative function associated with the ipsilateral structures, the preoperative functions associated with the contralateral structures in the brain, the patient's intellectual reserve, structural measurements from MRI are predictive, a variety of clinical epilepsy variables are predictive, and age variables and sex variables can also be predictive of outcomes. And over the past number of years, a number of predictive models and nomograms have been developed to aid in prediction of cognitive risks of surgery. And before talking about them, I just want to make the point that it's extremely important to identify the risk of amnesia in candidates for temporal lobe epilepsy. Now, here's an example taken from a recent publication by Robin Bush on a nomogram to predict verbal memory decline after temporal lobe resection in adults with epilepsy. And this is a predictive model based on a test that is commonly used, the Ray Auditory Verbal Learning Test, the delayed recall. And in this study, they looked at a large number of patients from multiple surgery centers, and they identified a number of predictors of decline after surgery. And they were then able to develop this predictive model. So what you see here is a point scale. And what feeds into the final outcome prediction are the following variables: the baseline raw score on the test. So this patient had a raw score of 10 out of a maximum of 15. And looking up at the point scale, we see that that gives 65 points. This patient was going to have a left temporal lobe resection, and that gives 70 points. This patient was going to have the hippocampus resected, and that yields another 60 points. So the total number of points in this patient was about 195, and then you can see that that yields a risk of about a 55% chance of decline. So that information can then be provided to the patient in discussing whether or not what the expected outcome of the surgery would be and whether or not that's a risk the patient's willing to accept. Recently, nomograms have been developed for looking at IQ and developmental quotient outcomes in children, and it's a similar thing. There's a point scale, and the authors were able to identify a number of variables that were predictive of outcome. So again, using this scale, you can advise parents about expected outcomes of the surgery in their children. So what's important is that the neuropsychologist be involved in the decision-making with the medical team to identify what we would consider to be the high-risk surgical candidates in terms of cognitive and behavioral outcomes. And we also want to be involved, it's very important that we're involved in feedback with the patient and preoperative counseling with the patient. And the family, of course, can be involved in this. And in undertaking this counseling, it's important to know what the patient and family's expectations of surgery are. We would want to provide a detailed explanation of the results and provide education about the etiology of the cognitive and functional deficits that have been identified. And what we find is that often this is the first time the patient or the family has ever twigged into the fact that the cognitive and behavioral comorbidities that the patient is exhibiting are also part of the epilepsy spectrum, that they are part of the underlying neuropathology, result of the underlying neuropathology. It's important in the feedback to discuss any predicted changes after surgery. And some people also include what's called prehabilitation for anticipated cognitive losses or psychosocial difficulties. So you may be familiar with the concept of rehabilitation, which is after the fact, after the injury. And in prehabilitation, we're anticipating a loss, and we're working with the patient to try to provide strategies to offset or lessen the impact of those losses on the functional impairment that they incur as a result of surgery. Now, recently, attention has been directed towards the concept of patient satisfaction with surgery. And this is now becoming a key metric in determining surgical success. As you probably are aware, our Canadian colleagues, Colin Josephson and Sam Weeb, and their colleagues in Calgary have recently published a scale to determine patient satisfaction with surgery. And what's interesting to me as a neuropsychologist is that there's this recent publication by Sally Baxendale showing that your patient satisfaction with surgery is not only dependent on postoperative factors, on recovery and seizure control and so on, but they were able to identify that there were also some preoperative factors that play a role. And importantly, they found that if patients had anxiety disorders prior to surgery, then that influenced their eventual satisfaction with their recovery from the surgery and the satisfaction with psychosocial outcomes of the surgery. So again, this speaks to the importance of identifying these factors prior to surgery. And if you know you have a patient who has anxiety, it's worthwhile having some intervention for that anxiety, and that will play out into a different outcome after surgery. Now, I want to speak to the importance of neuropsychological follow-up for surgical patients. So the neuropsychologist should not only be involved in preoperative assessment, but should also be involved in the follow-up of patients after surgery. And this was recognized eons ago by Penfield, who wrote, "It is not enough whether a radical surgery procedure has stopped attacks or not. We must know its effect upon the patient's ability to work, to hold a job, to study, the effect on physical and mental function, the effect on behavior, and on the happiness of the patient and friends." So this really speaks to the importance of what happens after the surgery. What has the surgery done to the patient? What has the surgery done for the patient? And this information is required in order to advance our counseling and our discussion of the cost-benefit ratio for not only the patient that we're working with at the time, but also that knowledge carries forward to our work with future patients. So in the post-surgical assessment, we should be evaluating all aspects of cognition and behavior that were assessed before behavior. It's very important that we use reliable methods to assess change. We know that there's error in our test scores, and we want to be sure that when we document changes that greater than the changes in scores that can be expected due to those error variables. So for example, if you had a patient who had an IQ of 95 before surgery, and they have an IQ of 96 or 97 after surgery, yes, that's an increase in score, but that is by no means a meaningful change. It falls within the standard error of measurement of the test, and it's not anything that one should get excited about. So we need to use reliable methods to determine what magnitude performance changes is a significant one. The timing of the assessment is important, and now there's lots of literature to suggest that the longer the follow-up, the more accurate the picture of postoperative outcomes. So in children, for example, some of the cognitive improvements, cognitive changes associated with surgery are not evident until 5 or more years after the surgery. And it's also important in the post-surgical assessment to identify whether or not there might need to be some psychotherapeutic input in order to maximize the patient's potential. So what can change after surgery? Well, I was talking about the risk of memory decline in patients with temporal lobe resection, for example, and we know that between 25 to 30% of patients do experience a significant deterioration in memory. And this deterioration is not necessarily restricted to resection of the language dominant temporal lobe. We also see changes after non-dominant temporal lobe resections. And language is at risk after dominant temporal lobe resection as well. So word finding difficulties are common, and they can represent a significant long-term problem for our patients. I just want to mention that I'm emphasizing temporal lobe resection because the greatest evidence base, the most publications have been done on temporal lobe surgery. Now, there's a particular group of patients who might be at particular risk. I'm calling this the double whammy. These are patients who show memory decline and they're not seizure-free. So they really have lost out in many respects. Excuse me. So on the right here, you see these data from a large sample of patients who underwent temporal lobe resection. And it turned out, excuse me, that 42% had great outcomes. They had no memory decline and they were seizure-free. About 20% showed no memory decline, even though they were not seizure-free. 25% showed a memory decline, even though they were seizure-free. And of these, about 6% experienced a significant postoperative decline in both verbal and nonverbal memory. So that was quite a significant hit for them. And finally, the worst possible outcome was seen in about 12% of patients who showed a memory decline and were not seizure-free. And again, of these, about 4% had a significant postoperative decline in verbal and nonverbal memory. So these are patients that we have to be particularly concerned for. And this study identified a number of variables that could be predictive of this particular undesirable outcome. So these patients were less likely to have hippocampal sclerosis. They had higher scores associated with the ipsilateral side of surgery. In other words, if the surgery was on the left temporal lobe, they had higher verbal memory scores than those patients who didn't show this decline. And on the right, it was higher visual learning scores. They tended to have lower scores associated with the contralateral side to surgery, and they had lower verbal IQ. So this is a constellation of factors that one could take into consideration when thinking about the likelihood of this negative outcome. Now, what about psychosocial function? Well, anxiety and depression occur in approximately 30% of patients who undergo temporal lobe resections. In some of these patients, they had pre-existing disorders and they reemerged, and in others, they appeared for the first time. They are de novo results. And this brings us also to the concept of what's been called the burden of normality. So quite a few years ago, Ferguson and Rapport identified that epilepsy could serve both as a weapon and as a shield. So it can have both positive and negative effects to the patient. Some of the benefits are that it might allow them to avoid difficult situations or to have an excuse for situations that are not optimal. And this concept was really investigated well by Sarah Wilson and her colleagues in Melbourne. And they developed a model of this burden of normality, where many patients do not show good psychosocial outcomes after surgery, despite the fact of getting good seizure control. And there are a number of factors that they have identified, psychological factors, behavioral factors, sociological factors, family factors, and affective factors, which can feed into this. So the expectation might be that they'll have surgery, their seizures will stop, and everything will be great, life will be great. And in fact, many of these patients do more poorly after surgery than they do before surgery. There are, however, improvements that can be seen after surgery, and there are a number of reasons to celebrate these improvements and also to think about the cause of these improvements. And some of these factors that might feed into these improvements are the concept of cerebral adequacy and cerebral reserve, what parts of the brain are still functioning well that can carry out cognitive functions. There are might be increases in functional connectivity, and relatedly, reduction in disruption in networks at the neurophysiological level, and also at the practical day-to-day living level. There can be reduction in disruptions. The patient is now able to do things that could not do because of seizures before. There can be functional release, so there might have been a spread of epileptogenic discharge to other areas of the brain, and that is eliminated, and that means those other areas can go ahead and function the way that they were intended to function. Many patients after surgery report improvements in sleep and a decrease in fatigue, and of course there might be reductions in anti-seizure medications that can result in reductions in cognitive and behavioral side effects. So I'll just end off by reiterating some of the points that I made before, that neuropsychological assessment is a collaborative effort. It's more than just attaining test scores. The assessment is critical for both preoperative investigations and for the postoperative follow-up of patients. And it will maximize the success of your surgery. It will help prepare your patient for surgery and can help ensure optimal adaptation after surgery. And this table on the right is from our Neuropsychology Task Force report that was published in Epileptic Disorders, which shows the key considerations that I have been discussing today. It's all nicely summarized in this table for you. So thank you very much for your attention, and I'd be happy to take any questions.
Thank you.